An acute migraine is a severe neurological event. It strikes as a sudden wave of neurogenic inflammation that rapidly disables the sensory nervous system. For decades, treatment relied heavily on repurposed drugs. That changed with the introduction of therapies targeting calcitonin gene-related peptide, or CGRP. Monoclonal antibodies and small molecule antagonists, known as Gepants, are now a cornerstone of modern neurology. This chart illustrates the accepted clinical baseline. When we look at preventive therapy on the left, both monoclonal antibodies and Gepants show robust efficacy. The bars for male and female patients sit level at a high mark. But when we move to acute therapy on the right, treating an attack that is already underway, the data diverges. The female response rises to a level of significant relief, while the male response barely registers above the baseline. This represents a massive divergence in clinical outcome. Two distinct biological groups are taking the exact same acute medication, but only one is reliably benefiting from it. The standard prescribing paradigm for acute migraine relies on an assumption of biological uniformity. This efficacy gap suggests that treating men and women with the same acute protocol may be ignoring a significant biological divergence. When researchers pooled the clinical data across multiple acute Gepant trials, they identified a clear, statistically significant benefit for female patients. Women averaged a 9.5% improvement over the placebo response at the 2-hour mark. We measure this kind of clinical benefit using the number needed to treat, or NNT. For women using acute Gepants, the NNT is 11. You treat 11 female patients to guarantee one achieves complete pain freedom directly because of the drug. Now, look at the male cohort. Their effect over placebo drops to just 2.8%. The NNT inflates to 36. In clinical practice, an NNT of 36 means the drug is failing to provide reliable acute relief for that population. The measured benefit is not statistically distinct from zero. This discrepancy requires a rigorous explanation. If the drug itself isn't the variable, it raises the possibility that the migraine attack is functioning differently in the male body than in the female body. Clinicians might question this data. The initial drug trials and regulatory snapshots reported that these medications worked effectively for men. The answer lies in the enrollment demographics. Looking at the pivotal trials, the enrollment starts at 100%, but it rapidly tapers down. The vast majority of participants were female. Only 10 to 15% of the total cohort were male. This skewed enrollment directly impacts statistical power. By the time researchers isolated that small male segment, the mathematical ability to measure a reliable difference dropped sharply, falling well below the required threshold of significance. These individual trials were drastically underpowered for men. They fell into the biostatistical trap of the false negative, where a failure to detect a difference is mistakenly reported as proof that no difference exists. Because the male sample size was so low and individual placebo responses can be high, the standard trial environments easily masked the acute failure of the drug in men. The initial consensus of equal acute efficacy was a statistical illusion, an artifact of clinical trial design, rather than an accurate reflection of human biology. Correcting this illusion required a different analytical approach. Researchers led by Pareka utilized a pooled analysis to bypass the mathematical limitations of those individual trials. This forest plot demonstrates their methodology. They combine data from trials for 3 different acute Gepants: Uber Gepant, Rima Gepant, and Zava Gepant. Individually, these trial lines hover ambiguously around the zero effect axis for males, but pooling the data artificially builds a large enough male cohort to achieve adequate statistical power. The statistical fog lifts, and the data point lands decisively on the side of no significant clinical benefit. Generating sufficient statistical power rewrote the accepted narrative, proving that the acute efficacy of Gepants diverges strictly along sex lines. If the drug fails to stop an acute attack in men, the immediate clinical question is whether the male body simply processes the medication differently. We evaluate this through pharmacokinetics, examining how the body absorbs, distributes, metabolizes, and clears a drug. This graph tracks drug concentration over time. Dedicated pharmacokinetic studies show that patient sex has no clinically relevant impact on Gepant exposure. The female and male absorption rates perfectly overlap. Men and women end up with the exact same concentration of the drug in their system, readily available at the target nerve sites. If the delivery of the drug is identical, the failure point must be the target itself. The discrepancy is pharmacodynamic, rooted in the biological differences between male and female migraine pathways. This introduces sexual dimorphism in nociception. The physical pain pathways in male and female nervous systems do not operate exactly the same way. The trigeminal nerve releases CGRP. In females, we find a specific anatomical link. Estrogen receptors are located directly on the surface of these CGRP-releasing nerve cells. This physical proximity drives the estrogen withdrawal hypothesis. A rapid drop in systemic estrogen levels, such as the decline right before menstruation, physically destabilizes these trigeminal nerve cells. This hormonal drop triggers a massive cascade. The destabilized nerve violently releases a surge of CGRP, driving severe neurogenic inflammation and pain. Because a female acute migraine is heavily amplified by this massive CGRP surge, intercepting it with a CGRP-blocking gepant is a highly effective intervention. Male pathophysiology lacks this cyclical estrogen amplifier. Without that hormonal trigger, the CGRP pathway is likely less dominant during the acute phase of an attack in men. Acute gepants are effective drugs, but in male patients, they are intercepting a chemical pathway that isn't the primary driver of the attack. We still have a lingering paradox. If male acute attacks rely on different chemical drivers, why do preventive CGRP therapies work universally across both sexes? To resolve this, we have to map the treatment phase against the biological mechanism. Preventive therapy relies on sustained, high-level blockade. This continuous action lowers the baseline hypersensitivity of the entire nervous system, providing universal benefit regardless of the patient's sex. Acute therapy operates differently. It relies entirely on intercepting an active attack in progress. For females, the hormonal CGRP surge is blocked successfully. For males, the diminished effect occurs because an alternative chemical pathway is dominating the event. The timing of the blockade interacts directly with the patient's biological sex. We are dealing with two entirely different therapeutic paradigms. This data dictates an immediate shift in clinical practice. Physicians must temper their expectations when prescribing acute gepants for male patients. If a male patient experiences a suboptimal response to an acute gepant, clinicians should maintain a lower threshold for switching to alternative drug classes, such as triptans. Moving forward, medical research must restructure its methodology. Clinical trials must utilize stratified randomization to adequately power male cohorts, ensuring we never again accept a statistical false negative as clinical truth. Finally, science must identify the undiscovered male-specific nociceptive targets that actually drive acute attacks in men. The data from these CGRP therapies shows that uniform neuropharmacology is an aging model. Recognizing and measuring fundamental biological differences is the only way to ensure that acute treatments provide reliable relief for every patient, regardless of their sex.
Thanks for watching. If you learned something from this video, please subscribe to the Concierge Care channel. You can find us at health.conciergecare.net. Follow our links to other videos on deeper dives into the selected topic and related articles on the discussed subject. Don't forget to enable notifications so you don't miss our next uploads and live events.